Hello, everybody. Welcome from the Council of Europe. This is the first webinar of the Committee on Bioethics ever, I think. And I'm welcoming all the delegations of the DHBio with us today. This webinar will last 90 minutes, and we're going to talk about the theme of COVID-19 testing, key human rights and ethical concerns. A few words of introduction. This is organised by the DHBio, but also within the launch of our strategic action plan on human rights and biomedicine for the next 5 years. And it's also under the auspices of the Greek presidency of the Committee of Ministers of the Council of Europe. The objective of the webinar today is really to look at 3 parts of the puzzle of testing and testing strategies and their implications. One is the current scientific understanding about what we know and what we don't know regarding this. Also, the ethical concerns surrounding these strategies. And then also, what are the human rights questions and issues that we need to address? Very important for our work in the committee. I'm going to queue up our chair of the DHBio, Tessie Askan, to make some introductory remarks. But before doing that, I just want to give you some information about how this webinar will unfold. So we have, after Tessie, we have expert presentations by 2 esteemed experts, Dr. Ross Upshur, who is co-chair of the WHO Ethics Working Group, who will look at the scientific evidence and the ethical concerns. And then following that, we have another presentation, also with slides for both, from Professor Dominique Sprumont from the Institute of Health Law in Neuchatel in Switzerland. And I thank them for their time and their efforts here. Then we will pass to open discussion, and that open discussion will be a mixed discussion with 2 designated DHBio members, Pete Mills from the UK delegation and Pierre Malia from Malta, and they will be asking questions both to the different experts, and we will also be receiving questions from you, from DHBio delegations by email, and we have an email address which should be coming on screen for you now in a green banner at the very top of the screen, and Lance Loff will be bringing those questions in after the questions from Pierre and from Pete. So we will mix them up. We'll alternate between written questions and oral questions. And then in the final part, for the last 5 minutes, what we will do, we will have a wrap up. We will have some final, very singular key messages from Professor Upshur and Professor Sprumont. And then we'll have some final remarks from Tessie Askan. So without any further ado, welcome. And the floor is yours, Tessie.
Thank you very much, Lee. So, yes, I also want to say welcome to our committee's first webinar. And it's the first one out of 2 on human rights issues related to the COVID-19 pandemic. We have identified some topics that we found were most interesting to discuss, in particular in relation to our committee's role. And we're trying to find the most relevant human rights considerations in this prevailing pandemic. And this first seminar is about testing and human rights concerns that may be related to test results. And we're in particular interested in understanding how accurate these tests are and if they can be considered reliable enough for making quite important decisions about the rights of individuals in different ways on the basis of these test results. Some of the human rights issues that are relevant to the DHBio mandate would be, for instance, integrity issues. When you, for instance, have a positive test result for antibodies, does it give you advantages in society? Does it give you advantages when towards working in a specific field or towards traveling, free movement? And another aspect that we've been discussing is equity and access to healthcare. And in this context, it probably means equity and access to tests. who should have access to the tests firsthand if there's not enough of them. So when it comes to the equal access perspective, you might want to make some exceptions in prioritizing testing certain groups if you have good arguments for it. And for example, you might consider it proportionate to prioritize healthcare staff and staff in nursing homes, but other groups that we should be prioritizing when starting to do testing at a larger scale. And in order to find the key ethical considerations in relation to testing, we're very excited to have Mr. Upshur and Mr. Sprumont with us today. So I would like also to welcome both of you. I would also like to ask you, because not all of us have a medical background, that you make clear when we're talking about PCR tests to find an infection, an ongoing infection, and when we're talking about serological tests for finding antibodies, as these are the two different types of tests, and they have different implications. So I would kindly ask you to be mindful of the technical terms. So with that, I would like to hand back the screen to you, Lee.
Thank you very much. You have the floor, Ross, and you have 15 minutes. Just tell us when you want to start the slides. Thank you.
If we could start the slides, I'd be grateful. Good morning, good afternoon, good evening, everyone. It's morning here in North America. It's a great pleasure and privilege to be with you today. I'm speaking solely from my perspective, not on behalf of the World Health Organization, even though I'm a co-chair of one of their working groups. So I can't see my slides as yet if they're not on. Okay, excellent. So I'll just, going from memory, the overview of what I'd like to approach, and it sort of picks up from what Tessa was saying. I'll explain the distinction between PCR testing and serology testing. I'll explain that at the molecular level, then at the patient level, and then to the population level. So that gives you my bone of where I am. I'm from the University of Toronto. And next slide, please. So I'm going to give a very basic primer on testing for SARS-CoV-2 and COVID-19. Then I want to talk about some ethical issues attendant to the science of testing itself that I think are often overlooked. Then I want to focus a little bit more about the use of tests with attention to immunity passports, though I'm welcome and open to talking about other ways in which testing strategies are being contemplated. I want to start with a disclaimer. I'm not a virologist, an immunologist, a molecular biologist, or an infectious disease physician. I'm a public health physician and primary care physician, and I'm a Canadian, and being a good Canadian, I'm going to start with an apology for any inaccuracies, mistakes, oversights in the presentation about what's to come next. Next slide, please. So if one thing is to be very clear about the purpose of testing, there's kind of an overarching concern that when we're talking about testing, we're talking about one thing. It's actually a fairly heterogeneous set of technologies and also has a variety of purposes. And purposes are linked to goals. And one of the things that we need to get very clear about in policy is why are we testing to what end? So we use tests for clinical purposes, for diagnosis and management of disease. We use tests for contact tracing, screening, and serosurveillance. We use tests for research, some of them therapeutic and vaccines, and we do tests on tests themselves. What I would like to do is problematize and ask the question about what kind of testing strategy we're thinking about when we're talking about using immunity status for various social goods that usually are assumed under the auspices of one's citizenship. And of course, there's individual curiosity. In certain jurisdictions, people are encouraged to get tests if they're concerned that they might have COVID, the so-called worried well. Next slide, please. So I want to start with a very basic understanding of what's going on at the molecular level. So you can see on this slide, it's a nice depiction of the way in which the coronavirus infects the human cell. We've only known about coronavirus as human pathogens since the 1960s. However, there's good reason to believe that coronaviruses have been circulating and evolving for millions of years, mostly among bats and avian populations. But you'll see up in this top corner under A, this thing called the cellular receptor, and we're now all familiar with this spiky, circle known as the coronavirus. And it makes its way into the cell by attaching to a receptor. And in humans, it's called the ACE2 receptor. ACE2 receptors are found in the upper respiratory tract, in the back of the nose and mouth, but they're most abundant in the lungs. Now, the viruses are very simple organisms, but they can't exist on their own. They need to have a host, be it another animal, or in this case with COVID-19, humans, in which they can borrow the assembly factory or the cellular machinery. So once it gets into the cell, it sort of opens up, it lets out its RNA, and then it uses the machinery of the cell to replicate itself. So basically, they're like mad photocopiers. They come in, they take over the cellular machinery of the endoplasmic reticulum, the ER over on the right, the Golgi bodies, and they just use that machinery to assemble themselves and then to spread copies of them out into the host. When we come down to B, this tells us how the receptor actually, how the body, the host and the pathogen connect. So you see these letters here, NTD and RBD. RBD is the receptor binding domain, and S is the spike protein. And the spike protein is present in all coronaviruses. And in fact, SARS-CoV-2 shares 80 to 90% of the same genetics as other coronaviruses. So it's this S protein and the RBD where the virus connects or docks to the receptor in the cell, and then that's how it gets into the cell. But important to us for today is how the host responds to the virus. So this is the virus coming into the cell, and when we talk about polymerase chain reaction, it's looking for evidence of the virus. So it's looking for the genetic information that the virus leaves that allows us to detect the presence of the infection. Serology works down in this domain here. So these MABs, PABs, these are the antibodies that the human host organism elaborates to, as you see where these lines are in B under the receptor, to block the docking of the virus into the cell to prevent it from making ingress into the cell. So when we talk about neutralization, it's the way in which these various different antibodies, and you can see there's several down under the B section, and those straight lines with the red below it are the ways in which antibodies serve to block the virus from getting into the human host. Now, not only is that the way that the immune system responds to the virus, these very pathways are the targets of therapeutic interventions, so monoclonal antibodies to the RBD or the spike protein, and the type of antibodies that vaccines will want to stimulate. So you can see the relationship between testing and intervention. So just to reiterate, A is how this virus makes its way into the cell, pirates the cellular machinery of the host to make new copies. A shows how it becomes connected, and B shows how the body, the host, responds to that. Next slide, please. So this slide just illustrates within a human, very schematically, how these tests relate to that viral activity. So again, our spiky friend, the SARS-CoV, you become infected, you're not yet symptomatic, and you can see up here, most of the tests are unlikely to detect the presence of the coronavirus. You can see when symptoms are increasing, then the probability of detecting the virus increases. So PCR, as we were talking about, detects the presence of viral genetic material in the host. So that spilled out set of proteins that I illustrated in figure A on the previous diagram. And that happens intensely. So we're going to focus mostly on nasopharyngeal swabs, but you can see there's other places where you can isolate the virus from: stool, respiratory tract. There's interest in isolating it from the saliva. And it's most likely to be picked up in the nasopharyngeal swab in the first couple of weeks of infection. And you can see that there's a lag before antibody response starts. And first you have the IgM, and it declines, and then you have the IgG, and it persists. So PCR are likely to be useful in detecting the virus for the diagnosis of the disease early in the disease. Antibody response, which is the host, that first diagram under B, the host responding to the disease, that's detected usually a week or two later with two different sets of antibodies, the IgM, which is the first one, and then IgG, which is the persistent one. Next slide, please. Now, in a perfect world, so I'm more of an epidemiologist than I am a molecular biologist, so I'm much more uncomfortable domain with this. In the perfect world, tests would only have two outcomes. If the test was positive, you had the disease. If the test was negative, you didn't have the disease. But the unfortunate, and it's part of this, and most people who watch a lot of medical dramas on TV believe that all tests are positive all the time when the person has the disease, and if you have a negative test, you don't have the disease. But there is this ineliminable nature of false negatives. In other words, the test is negative, but you have the disease. As a clinician, these are the ones that haunt you. And if the disease is positive, and in fact you don't have the disease, and that's the false positive. So false positives and false negatives are very much a concern in basing decisions in policy on testing. Next slide, please. No, so this just tells you how you calculate so tests have properties of sensitivity, which is the true positive rate, and specificity, which is the true negative rate. And then there's what's called the positive predictive value of a test. So now we're looking at what happens at a population level. And this just shows the interplay between sensitivity, specificity, positive predictive value, and prevalence. And this is critically important. If the prevalence of the disease is 0, then all positive tests will be false positives. And as you can see, as the prevalence goes up, the probability that the test, if it's positive, is a true positive goes up. And there's thresholds at each level of sensitivity and specificity wherein you cross the line where the test is more informative than less informative. And you can see here right immediately that there's a jeopardy. You actually, for your test to perform well, you need a reasonable prevalence in the population. But for there to be a relevant, a robust prevalence in the population means that your public health measures have failed. You actually don't want your prevalence to increase so that your tests are useful, because that would be a failure of containment. Next slide, please. So I'm going to illustrate this with just a simple test. So you saw in that previous slide, in that middle yellow bar was the 95% sensitivity and 95% specificity, which would be a fairly good performing test. Now assume that the prevalence is 5% in the population, and take that population to be 10,000, which means that you have 950 positives. Then in that case, half of the positives would be true positives, and half of the positives would be false positives. In other words, serological testing or any form of testing in this circumstance would be no better than a coin toss, because the positive predictive value is only 50%. So next slide, please. So there are an abundance of tests, and this is just a screen capture from Find. If you go there to this site, you will find hundreds of tests, PCR, immunoassays of various different types, focusing on any different element of that cellular architecture and antibody process that I showed you in slide 1. So there are hundreds of these tests by multiple companies and academic laboratories around the world being developed. Next slide, please. So there's limitations to tests. As you saw very clearly depicted in that schema from the JAMA article, if you test an individual too early, you can result in a false negative, and that would put the population at risk. If disease prevalence is low in the population, as I illustrated, then the number of false positives is likely to be high. But the most important thing with respect to our current state of knowledge of serology testing and antibodies is that there is no evidence that antibody production can confirm if an individual is immune from COVID or for how long. It may indicate exposure, but given the high rate of false positives, it may not even be a good marker of exposure in the population. Currently, there is no agreed upon reference standard or gold standard for testing, and as I mentioned, there's a large number of tests and approaches being evaluated. So it's a very dynamic environment, and my simple advice is don't believe anything 100% quite yet. Next slide, please. So we often don't talk about the relationship between values and science itself. And I want to raise three issues. One is the concept of inductive risk. This arises from philosophy of science and from long discussions about the value neutrality of science, or whether values enter into science and how they enter into science. This has started with Carl Hempel in the 1950s, but has been revised and revived and is being actively discussed in philosophy of medicine circles, particularly the work of Heather Douglas, and more recently in philosophy of medicine and epidemiology in a book by Jacob Stegegna at Cambridge on medical nihilism. Essentially what this argues is that because of the fallibility of testing, there is always going to be predictable harms from false positive and false negative rates. And the simple point is detecting or determining the acceptable rate of harm cannot be bootstrapped empirically, but actually requires an explicit identification of values and choices at the time that you're embarking on a testing strategy. The second point is that the optimal performance of tests varies by context, and the acceptance of the responsibility of harms from the fallibility of tests needs to be explicitly negotiated and acknowledged. So as a clinician, I know that we have imperfect tools for dealing with the illnesses that befall humans. That happens, it's nobody's fault. But we do know, for example, when you're embarking on a screening test, because all harms attendant to a screening test are iatrogenic or system-created, that you need a mechanism of responsibility. And thirdly, framing discussions in terms of immunity itself may obscure issues around challenges faced by those who may lack immunity or have impaired immunity, and this may be a substantial proportion of the population, particularly in places like the EU, where you have an aging population and the phenomenon of immunosenescence. Next slide, please. We'll try to speed up a little bit. So I want to focus a little bit on the so-called immunity passport. Positive arguments have been raised, particularly by Prasad and Emmanuel recently, in which they argue, so the idea of an immunity license is that there will be some sort of a serological test that tells you that you have immunity to SARS-CoV-2. This assumes that duration of immunity and reliability of assays has been worked out. The argument that they try to make is that there's going to be a need for careful implementation and scientific support, but there's nothing that makes them unethical in principle, because they have these desirable properties of enhancing liberty, maximizing benefits, allowing immune people to engage in economic activity, and provides a means to protect the least advantaged. Next slide, please. However, there are numerous concerns raised by these immunity passports. In fact, many of these concerns are raised by testing strategies that might be employed, contact tracing and follow-up. Many of them are about behavioral incentives. So, for example, would people seek out infection in order to seek an immunity passport or certificate? Would there be a black market? Would people steal results? There's concerns about privacy issues of very sensitive health information. Stigma is a big issue. How are we actually going to determine who has these properties and passes. I know in certain jurisdictions they're thinking of using facial recognition software and certain codes on cell phones that would permit you to enter certain areas and not enter others. Issues around fairness, about coercion, about differential impact, about social and global justice, erosion of solidarity. The Nuffield Council released a very nice analysis of some of these issues, and mindful of time, I imagine we will engage in a discussion on each of these issues as we go forward. Next slide, please. So the WHO itself issued a scientific brief on the 24th of April, in which it said currently there's no evidence that people who have recovered from COVID-19 and have antibodies are protected from a second infection. And this was kind of advice to try to push against the notion of immunity passports or risk-free certificates. And I think that advice still holds in late June to the same degree that it held in April. So I'll stop there and pass to Dominique. Thank you for your time and attention. I hope this was of some value.
Ross, thank you very much. That was very informative about what we know and what we don't know, actually, as you said. Without further ado, Professor Sprumont, the floor is yours. You have approximately 10 minutes. Thank you.
Thank you very much. I wait for my slides. They may come. Well, while they are coming, I may introduce myself. You made a warning about all the specialty you don't have in medicine, but I'm not even a physician, so you have to be very prudent listening to my comments, and I apologize myself. I'm not Canadian, I'm Swiss, and we tend also to be very apologetic when necessary. I'm a professor of health law, but I was also past vice director of the Swiss School of Public Health. I am currently the chair of a research ethics committee, and I think what I'm going to present is going to be a reflection of these three positions I have been sharing. So if I can have my first slide, thank you. Next. Well, the starting point, I think it's very important. Here is a paper that was published in the JAMA at the early stage of COVID-19, which provides very early important lessons from COVID-19 from a Chinese point of view. The green box at the bottom of my slide was not in the official publication, and for good reason. I'm referring to Li Wenyang, the physician who was the very first to warn the community about the emergence of a strange disease that was appearing in Wuhan, and this poor fellow was condemned for making false comments on the internet. Actually, he was a very courageous man, and he died from caring for his patients later on February 7. And I think we have to remember that, because in the human rights point of view, at the very birth of this pandemic, you can see the violence also of the state and the complexity of responding to a virus on one point, but to a universal crisis. And I think we have not to limit the COVID-19 as a virus, as you have illustrated before, Ross. We are talking about a disease that has tremendous social and human impact and economical impact. In terms of virus, what is interesting is that it was identified very early. And if you look at the slide as well, you can see that the test, the very first test, was available a few days after the official recognition by the Chinese authority that there was a problem, and that WHO later on recognized as an international health emergency, and then in March as a pandemic. Next slide, please. The real important lessons for me concerning COVID-19 is that we are definitely confronted to a world of uncertainties. forgive me, I didn't pick up Swedish and all the other language. I took Latin, Mandarin, English. I hope you will cope with that. But the idea, what are we talking about here? And there are so much uncertainties, and I find extremely interesting. You have to know that while preparing this webinar, we have made a first workshop yesterday together with Ross and Lee and Lawrence from Council of Europe, and one of the key elements, it was the uncertainty. There are a lot of things that we still don't know, and we have to cope with that. And as a lawyer, I am extremely cautious about that, but also as the chair of a research ethics committee, because we had in Lausanne only, it's the canton where we had the most cases in Switzerland, so we had many research projects, and I could see the struggle of the scientific community to understand what was going on. And I could see how difficult it was to decide to move in, for instance, developing a trial with hydroxychloroquine or remdesivir and other drugs to be tested, while at that moment people were dying at the hospital, not because of a lack of drug, but because there was some mistakes, but unfortunate mistakes, because we didn't know how to deal with the patients, and so some patients passed away just because the intubation was not done properly. So there are so many uncertainties. Next slide, please. That brings me to the purpose of testing, and we didn't coordinate ourselves for the slides and for the questioning. It has to be stressed, but I find interesting that Ross is following very similar path of thinking on this. The testing is part of healthcare, and it's a very fast-moving field. We heard that there are two types, and Tisa was clear to remind us that we have to differentiate the PCR, which is a diagnostic test, from the serology test, which is past infection. The way the PCR test is done varies as well. We have the nasopharyngeal swab, the throat swab. We also have the rectal swab. In fact, we did not mention so far, but beside those two tests, we should also mention the sewage testing now that is being developed. Sewage epidemiology that is extremely powerful, and that has some advantages in the sense that it is not targeting individuals but community. It raises other questions. But what is very clear is that testing is a medical and public health priority. It is, in fact, very interesting. And I look at the Swiss situation where we were fortunate in the sense of having a very solid and reactive healthcare system with enough emergency hospital beds and so on. But at the very beginning, I was puzzled by the fact that a lot of energy, more energy was spent to develop hospital beds where we did not enough, in fact, about testing. And Switzerland paid also partly the price of being too slow in starting the testing. So the diagnostic, the PCR, has immediate interest for the individual care and, of course, for its potential isolation, quarantine. But it has also a very important dimension for epidemiology. We need to know how many cases are in the community at a given moment to be able to follow the spread of the disease and to take the preventive measures, but also organizing the fight. Now, with the serology test, and I will fully support, and of course I will not disagree at this point with WHO, but on the fact that there are no guarantee of immunization, and the so-called risk-free certificate today is, I would call it wishful thinking, in the sense that there are basically no signs that past infection provides clear immunity for the persons who are concerned. So this is why from here I already erased the idea of using all those tests to develop immunity passport. It is totally premature to do that. Next slide, please. Now, in terms of human rights, I will distinguish on one hand the right to health, which concerns all of us, and I say healthy or unhealthy people, I will differentiate the right to health from the right to healthcare. And keep in mind the international health regulation, as well as any of your national regulation aiming to fight against epidemics, is not so much directed to care for the sick. It is meant to protect the healthy and to protect the functioning of the society and the functioning of the economy. And so this is important also to underline, I think, a wrong assumption to differentiate, on one hand, the right to health to the economical freedom. And you see a lot of political debate about opposing the two, while actually there will be no economical freedom without a healthy population. And so they are combined together. In fact, the international health regulation conception came from the idea that we have to limit to the maximum as possible the restriction on the economy that could be provoked by an epidemic or a pandemic. So the right to health here has to do with, of course, the need of non-discrimination that was mentioned before, but also the necessity to protect the autonomy of the sick as well as the healthy ones, and the privacy. For the right to healthcare, and looking more specifically at the test, because testing is part of healthcare, the test must be evidence-based and meaningful, and I'm not going to repeat what was said about sensitivity and specificity, but it is a matter of fact that we are still on the process of testing the test, and there is a lot of progress that we can still expect. Another key element for the right to healthcare is the access, the availability of this test. And at the beginning of the epidemic, the pandemic, access was limited, and there was some choice to be done. And of course, that will raise a question of how to prioritize the access to healthcare. There are essential workers, there are vulnerable populations, so there are choices to be made. Above that, of course, you have the informed consent that is a necessity. You cannot impose a test on the human right point of view. It has to be voluntary. But to be voluntary, it has to be affordable. Some people can just not afford it. And it's interesting, again, taking the Swiss point of view, because we are certainly one of the wealthiest countries in the world. And before 2 days ago, it was uncertain who was paying for the test. The sickness funds, the social insurance were saying it was not their job. The federal government was hesitating, the cantonal government was hesitating. So it was not until a day ago that the federal government decided that every test should be free of cost. Until that moment, it is clear that some people were reluctant to be tested because of question of financing. And last but not least, there is the issue of confidentiality. Who should have access to the results? How the results should be communicated, whether they are positive or negative, and this is important. Next slide, please. Now, I'm trying to summarize those key issues in human rights with the strategic action plan from the committee that you are representing, and I think there are two pillars where certainly actions are possible, and there are some connections with this strategic action plan, as well as your mandate. There are issues of governance. And the first element, which is fundamental, is that the test must be evidence-based and meaningful. And when it was said before, some of the tests are done for research purposes. Some of this research is only meant to test the tests themselves. And of course, those tests should not be presented as evidence-based, and they should be treated very carefully for the participants, because the meaning of those tests for the participants does not exist. There is a scientific research interest, but no direct or even direct public health interest for that. To make sure that those tests are evidence-based, they are regulation. And I don't think we need specific additional regulation. There are very clear regulations for diagnostic tests, for laboratory or healthcare professional, and they are enough. But they have to be followed. And my concern, if you remember, the US FDA made mistakes at the very early stage of the pandemic and failed to make sure that the tests put on the market were accurate. And this is a concern, and I can understand for the population a loss of confidence sometimes in their authority. And this is something extremely disturbing, I think, for the follow-up of the pandemic and our capacity to answer. Next, of course, the test must be made available and in a transparent way based on clear principles. And this is linked to international solidarity. There are countries which are so wealthy they can buy the test in advance, they can get excellent deals with companies and making sure they will have access to the test. And this will also be true for access to treatment, for access to the vaccine. But no, we are all the same human community here. We are the world together. And I think unless we make sure that the least developed countries within Europe, for the Council of Europe, and in the world for all of us, this is important to make sure that the tests and the treatments are available worldwide. And of course, in terms of governance, making sure that you have a proper data protection in place is fundamental, because the risk of discrimination is high, especially that there are wrong interpretations that are being used. And interestingly, in the Swiss law, we have developed now an application, for the tracking of the positive cases. And this is a criminal sanction if somebody imposed to have the apps to get access to a service or to a profession and so on. So the data protection is one element, but we need to have tools to implement those data protection to make it efficient. Last but not least, there are issues of equity. And protecting the most vulnerable against all forms of discrimination here is a central issue. I'm very concerned about the migrant situation right now. If you look at Singapore, who was expected to be the world champion in fighting the pandemic at the early stage, and there has been a lot of scientific papers about how Singapore was doing so well, until they realized they had a migrant population that was trapped in dorms where they were more than 20 together, and suddenly they had their real first wave of coronavirus. And so the migrants are a real concern. The people with the low revenue, imagine in Geneva, one of the wealthiest countries in the world, where they distribute thousands and thousands of bags of food every week right now. It's extremely concerning. And so access to the tests for those people is fundamental. And the financing, of course, of those tests is a priority. When you say that in the US, you have a genius, stable genius who is fighting against universal healthcare, at the moment we need people to pass the test, is extremely worrisome. I hope that in Europe, thanks to the Council of Europe and the human rights that it's defending, it is not happening at such a large scale, but we have to be concerned about that. Last but not least, and that will be my final remark, I want to insist on the fact that the international health regulation, which is a central tool to fight against the pandemic, should be more connected to human rights. There has been a constant request in the past evaluation of the past pandemic, Ebola, Zika, H1N1, and at each case it was pointed out by expert committee that human rights was under-evaluated, and it should be a systematic tool to make sure that the fight against pandemic is done properly. It is not, in fact, only a matter of human rights. It is a matter of public health, because the better you protect the human rights, the better you protect the health of the population, so the faster your economy starts. So there are also very utilitarist, in a liberal point of view, arguments to defend human rights in this situation. Thank you for your attention.
Dominique, thank you so much for that presentation. That was very complimentary to the one of Ross. Thank you to both of you for your for them extremely rich insights, and I've learned a lot. Now we're going now to pass over to the next part, which is the open discussion part with our audience with our DHMO members. And I'm going to queue up Pete Mills, first of all, UK delegation, to come in with a question to you. Before that, I would really encourage delegations to send emails with questions if needed to the email address which is on the top of the screen and which has been sent to you prior to this webinar. So please do not hesitate to come in. We have now really 40 minutes before we begin to wrap up. So I'd like to pass the floor to Pete Mills, please. Thank you.
Well, thank you very much to both Ross and Dominique for those really clear and helpful presentations. And I think, there's knowledge about the spread of the COVID-19 pandemic and about its the human response to it is developing all the time. So it's very difficult to give a clear and up-to-date presentation. But I think you put that in a really kind of helpful context for us. I just want to begin the intervention by making a couple of observations, and the first relates to Ross's really helpful slide about human immune response. And I don't want to put him on the spot because I take notice of his disclaimer, but I just wanted to mention that I think one of the things that seems to be perhaps not under-researched, but understood, if that's if I can coin that term, is the importance of the T-cell response in fighting SARS-CoV-2 infections, and in particular T-cell memory as a potential marker for protective immunity, something which as far as I understand it, we don't have a test for currently. So that looks like a really kind of important missing piece of the jigsaw. And one of those, the outline of a piece of uncertainty that we really need to fill in, it seems to me. Ross, you mentioned the positive predictive value of immunology tests. And you drew attention, I think, really importantly to the fact that it wasn't simply the test performance that mattered, but also, if you like, the consequences of the limitations of test performance. In other words, it's not only the fact that there is a certain level of false positives or false negatives, but that using a testing program or having tests in circulation that have those performance characteristics has very real consequences. And those consequences are things that, as a matter of policy, populations need to decide how they are going to accept. So that's a really big and important part, I think, of how you use tests within any given setting. So really what I wanted to pose is this sort of basic question about what use testing can be. And it's clear that in the course of the epidemic in most states, restrictions have been placed on the exercise of people's civil liberties, what we describe as lockdown, in other words, restrictions on movement and assembly. And one of the potential uses of testing in all dimensions is the fact that it potentially enables us to modify those restrictions in a way that allows some people to enjoy greater liberties without, in principle, harming others in the process. So, you put up a nice little quotation from Zeke Emanuel and Prasad's paper, where they put almost a kind of strong libertarian case, where they suggest that if there is a presumption of liberty, and should there be any way of relieving some people from the restrictions on their liberty, there is an obligation on states to do it. So in some senses, one could see in that a kind of prima facie argument for introducing public testing programs, if those programs can help to differentiate between populations who are at risk and who are at lower risk. On the other hand, of course, with testing programs, we need them to be voluntarily embraced by people. We don't, because otherwise we're just imposing one infringement of liberty where we're in place of another. So, and by and large, testing programs are only going to be effective if sufficient numbers of the target population are tested. Otherwise, we'll just miss the people who might well be spreading the disease. So in a sense, with what we're dealing with here is a problem, a fundamental problem of collective action. So this sort of brings me on to the thing that I'd be interested in your views on. Just looking across the way in which policy has been handled by a number of different states, there seems to be at least two ways of going about this. One is to employ what you might think of as a kind of nudge or cajoling way of getting people to participate in public health responses or submit to testing and things like that, which involves, for example, normalizing testing regimes, creating conditions that make testing, for example, the access to a condition of access to goods or services or to employment, for example. Very much in the National Health Service in the UK, people are being offered tests as an expectation if they're working in various areas that expose them to infection. So this is effectively a way of kind of presenting people with a bargain. You can have liberty as long as you comply with a particular kind of regime. Another way that people seem to have gone about it is more to appeal to a sense of solidarity or civic duty. And what I'm particularly interested in, I'm kind of interested in why public health measures fail. And within that, the importance of sort of transparency and community engagement, the level of trust in government and institutions that will contribute to or define the approach that's taken. So I'd be interested in your reflections on how to go about that sort of policy problem. Sorry, I'll stop there because I realise I've been speaking for a rather long time. So.
Thank you very much. I'm going to open it to Dominique and to Ross. Who wants to take the floor?
I'm happy to start and then let Dominique. So the point about the T-cell immunity is an excellent one, but then again, the other issue is about its duration. And one of the big problems always, particularly in the EU and North America, is aging populations and immunosenescence, which is going to be a big issue if we're going to go down the road of using so-called immunity tests to allow people to do things. I want to start at the bottom with the trust issue and talk about failed opportunities of societies and public health leaders to actually listen to some of the literature, scholarship that started to emerge after SARS. So I was working in Toronto during SARS, so I had firsthand experience of being a quarantine enforcer. I was taken from my avuncular position of being an academic family physician, and because I have public health training, I went to work on the response to do epidemiology, and soon became somebody who was in charge of making sure that people upheld their responsibilities when they had been ordered into quarantine. So we learned a lot about this notion of restrictive measures, about public trust, about the limits of state authority in emergency situations and not in emergency situations. And with the group, we had a research project over a decade where we did considerable public engagement and understood the fundamental importance of public values for maintaining trust and solidarity. And for some reason, nobody took this seriously. It's as if if you go back to the 90s when the emerging infectious disease paradigm came out, everybody kept saying, we're going to have a fairly major pandemic sometime within our lifetimes. So there's a set of things in which we should have been predictably prepared for. So it's shocking to me that connections to communities, citizen panels, citizen juries, all sorts of means in which public health and policymakers could convene tables where some of these very difficult normative discussions could be had, and at least not absolute, like, this is what we're going to do if X happens, it's not going to be algorithmic, but at least the communication lines, the tables were there with the expectation that very difficult discussions were going to have to be had, you know, starting even from how you're going to get ventilators allocated when that was the concern, to how long we're going to keep lockdowns in, how we're going to walk out. So we could have managed this a lot better by building trustworthy and trusted communication levels, by having outreach from policymakers and public health to communities. And now we have a very narrow window of opportunity to do that. So if we're going to talk about first waves and second waves, if I were in charge of a public health organization or had a Ministry of Health, I would be creating citizen panels. I would be involved in engagement on these issues and setting up, you know, deploying your bioethics specialty, right? You guys have a lot of depth of experience in negotiating and navigating complex ethical situations. Bring the tables together now. Recognize that the perfect is the enemy of the good here, because bringing people, one thing we learned in Toronto during SARS is that bringing people together, having them work together under exigent circumstances is probably the best trust building exercise you can ever have. You don't want to have to go through it, but we noticed that 2009 H1N1 in the institution that I work in was a very different experience than 2003 SARS. 2003 SARS was like a bomb had been dropped. Nobody knew what to do. Nobody knew who to call. There was no connections being made. 2009 came along. We knew who to talk to. But then now 10 years later, all of those connections have been frayed. So there's a lot that we can do. And then speaking to this, just one other point you raised about what are we going to do with data? Let's presume there's a future state where we have reliable evidence of enduring immunity. Let's presume we have that. And so you've got this presumption, states are to exist to, that the sort of the liberty first argument. We might actually think about reciprocity in times of emergency, where people who have certain traits can actually provide socially useful services. Because of, we can't let things fall simply to, brute luck egalitarianism, that some people are free and unencumbered because they have an immune status. We don't operate many societies by giving, complete free rein to liberty without some sort of reciprocal obligation to society itself. And that's something that I think could be explicitly discussed and negotiated. So I'll stop there and turn it over to Dominique.
Oops. Dominique, please.
Yes.
Thank you.
Thank you. Thank you, Niels, for your questions. They are very challenging. But I think the starting point when you speak about the public health failures, I think it's a bit too early. At least if you look at the European point of view, I will be in the US or in Brazil, certainly I will have a different approach. But if I look at the European situation, you have a variation of progress of the pandemic, country per country, depending on when they were touched, how the system was organized, how the government reacted. But you can also have a positive view of the situation until a few days ago, because you can see the curves now is starting to catch up again, unfortunately. You come from a country, unfortunately, that is still really touched. And this is a matter of fact, there are variations within Europe, but in some European countries, there has been quite a success in a way, and it could have been worse. And if I look at Italy, North Italy, and what came later to Switzerland, we were expecting a much worse situation in Switzerland than what happened at the end. And one of the elements was that the population very quickly adopted the proper behavior. And when you speak about trust, this is interesting, because the trust that we have between each other is different from country to country. It happens Switzerland is a country where we have very high trust of each other. If you will compare that to Turkey, for instance, or to other countries, there will be very different story. So how you build that trust is not based on the norms, on the rules. And we have a conservative, a nationalist party minister surprisingly said something I thought was quite smart at one point. We see the issue is not about norms, it's about behavior. having people adopting the right behavior, and it's very different from one country to another. In Switzerland, we managed not to have a strict lockdown. In other countries, it was implemented in a dramatic way, especially if you look at China. When you see that they were blocking the doors of individuals, keeping them in house, that was terrible. It was shocking, and I'm happy that so far we didn't see this kind of situation in Europe, and we have to be very cautious because public health is an extremely powerful argument to impose restriction to human freedom and to human rights, and this is a constant, concern because. Of course, there is the principle of subsidiarity that is embedded in the IHR and in the national regulation implementing the international health regulation. But the understanding of this principle of subsidiarity is very different from one place to another. And the Council of Europe, in that sense, has an extremely important role to play, not only within the Council of Europe, but also at the world level, us being a permanent observer at WHO and an active international national organization, regional organization. And for that, again, speaking today about public health measures failure is something that we will be able to confirm in a few years. The historian will be able to do that. In today's situation, you can see that some countries are reacting and resisting better than others, and this is based on this principle of trust. And it was interesting, Tessie coming from Sweden, I found very interesting that the Swedish were telling US Republican, showing Sweden as a good example, when the Swedish were telling the American, well, you have to trust your government and to behave correctly if you want things to be working. And even there, Sweden has suffered and is suffering right now a difficult situation. It's very difficult to make lessons today, I think. But again, if you have a clear application of the principles and respecting the human rights, individual human rights and protection of the vulnerable population, I think you can reach a rather positive example, as was given by Ross on Toronto situation with the SARS in 2003.
Thank you. Dominique, thank you. Thank you. I think we're all nodding here. I think you're all nodding out there to the comments that you're making. They're they resonate very much with us. Time is running away from us. We have around about 20 minutes left. Before I come to Pierre, I want to pass to Laurence because we have some questions. I'd like to Laurence to tell us what's coming in from email. Thank you.
Yes, thank you very much. We have quite a number of questions, so I will try to put at least 3 questions if this is possible. We'll see, but we will ask the speakers maybe to try to reply briefly if it's possible, even though I'm aware that some of the questions would call upon some answer that would need to be developed. And the first one is about the good way to balance between the need for privacy of the result of individuals and the need of institutions to implement quick public health measures to avoid the spread of COVID-19. And I would add to this in a context of uncertainty to the test results. So that this balance between privacy and public health interest, or how to do that.
Well, if you want, I can jump. Thank you. I can jump on it. Can I go ahead?
Please go ahead. Briefly, thank you.
Okay. Well, there is a clear need, public interest, for having the public health authority access to some basic data. And the way it is done may not be a breach of privacy, a breach of confidentiality, because there are ways of collecting data that are aggregated, that are collected so that individuals may not be targeted afterward. But this is important that such approach is embedded. But it goes back to the previous discussion about trust. We need to trust the public health authority at one point to make the best use of those data. And only the authority. I would be very reluctant that those data goes outside of this specific group and that are being used for anything else but for public health measures and actions. For employer, for others, for the neighbors and so on, this is none of their business, and the privacy has to be protected. And when you saw the system in South Korea or in Singapore, in China, where actually you could know that your neighbor was affected, this is not something that will be acceptable based on our sensitivity about human rights under the European Convention on Human Rights and Fundamental Freedom, and not only the Convention of Oviedo. So the balance has to be certainly well done, but we need to protect this privacy and make sure that the data are being used only for the public health authority and for nothing else. There is a clear indication that in some countries this is not the case, and that public health emergency is being used by totalitarian or almost totalitarian countries, also within Europe, to abuse citizens, and this is a big concern.
Thank you, Dominique. To get us to move on, because we don't have so much time left, and I'd like to include as many questions and people from the outside as possible. So I'm going to pass to Pierre now. Pierre, if you could give us your question briefly to the experts in a succinct manner, so we can include other questions afterwards, please. Thank you.
Okay, thank you. Sorry, there's not much time left, so I'll just go to the question. Well, basically, there are two things which are being really discussed here. It's a question of trust and a question of this immunity passport, as it were. We didn't mention vaccination, so we won't go into that, because once we have vaccination, of course, probably the immunity passport question we would not have it. But the main question is that unless, let me put it in an example, unless we have a vaccine, aren't the vulnerable groups the people who are really going to be discriminated against if we have immunity passports? For example, the elderly, or the people who have actually chosen to obey their government's regulations, as it were, and stayed inside. I mean, these people are not going to be immune, and now they're going to be discriminated against. So that is the question. Immunity passport, as it stands, will be discriminatory. It won't be if you say, look, if you're going to care for the elderly, you need to be immune. So I would want to hear your feedback on that. But before, the main question is, public health is not always a utilitarian measure, and this is where many people go wrong. I'm happy to have heard Ross say that, we have been doing work on this. We've participated in a disaster bioethics EU project, not EU, sorry, it was a cost project, including even many more countries, 4 whole years, and writing papers, and we presented this to the WHO as well. As co-chair, you probably have access to all the papers, and one of them was actually when public health actually does become utilitarian. I mean, I cannot, my colleagues in the DHBio know I cannot smoke in public because I cause harm to others. But I can eat a hamburger in public, even though I can cause harm to myself and to the economy. So there comes a point where we have to think not in utilitarian terms, but on deontological terms, principles. I have the freedom to eat my hamburger. But it is not about hamburgers when it comes to utilitarian choices. It is about that smoking, which not causes harm only to me, but also to others. And this is what we're talking about here. I mean, normally we would not oblige people to vaccinate themselves against influenza. But when the disease comes big enough that the health of the public is now becoming a public health issue, then yes, we can make obligatory vaccination. But if we don't have obligatory vaccination and we introduce the immune passport, what public health trust is going to be created when we know that trust comes from, we have this maxim of you get wisdom comes from public wisdom, and public wisdom comes from knowledge, and that knowledge comes from information. And there's the process of understanding. And the information we are giving the public here is that, look, for me to allow you to go outside, you're going to have this tag of an immunity passport. Without me giving you any vaccine, notwithstanding all the mistakes we did and all the lack of solidarity. So wouldn't you think that immunity passports, unless we have vaccination, cannot be seen as a public health measure unless it's in a totalitarian state mode? So that's my question.
Pierre? Yeah, thank you very much. That's an excellent question. Before you come in, Ross, I think you wanted to come in. Lawrence, we want to combine a question coming in from Lawrence, which is linked to Pierre's question there. Lawrence, and then we'll come to Ross.
Thank you very much. There was a question about immunity passport, and the question was addressed to Ross. To elaborate, if you can, on your understanding of discrimination and discriminating criteria in regard to immunity passport. So I think there are some elements, and for the sake of time, we're trying to combine questions around the same subject, so to say.
Okay, Ross, please.
Yeah, so lots of issues raised in that in Pierre's comments. So just to sort of drill down back to my question or my concerns around inductive risk, the only way you're going to have a significant proportion of the population that's immune, and that can be detected with reliability by the tests, is if you have significant transmission in the community, which means that measures have failed by any standard, right? So if you just look at that positive predictive value. So I don't like to use the term immunity because immunity is an interesting construct, and I think it frames. So have we learned anything from all of the ethics of ability and disability about how language frames possibility and norms? So when we even start to talk about immunity and passport as if it's a thing, we're already conceding an awful lot that I think needs to be problematized, largely because of issues. So we don't even want to get to the point where we have to talk about whether these are discriminatory or not. I think we need to interrogate whether they should exist in that form of language in the first place. So is it immunity or is it measuring antibodies, particularly in light of Pete's point about, T memory cells? So there may be significant components that relate to immunity that will be completely missed by the tests that we're going to try to use. So it also doesn't get away from the inductive risk that there's going to be errors in those tests. So let's not even talk about immunity, and let's not even talk about passports. Because if you engage in that discussion, you're giving legitimacy to the entity itself. And I think there's good reason to question whether we should even go down that route, because if they're going to be measurable in the population, it means that the virus has been spreading. So I think there's a lot of work we can do to fend off those considerations. And talking about them as if they exist is conceding far too much at this stage, in my view.
I cut, sorry. We'll be having another webinar on health literacy next Tuesday, which I think will touch upon these issues of the words we're using. I'm going to try to prompt Tessie. I know she'll be coming at the end to speak, but I wanted to know, Tessie, whether you would like to come in at this point. We have 10 minutes before the wrapping up. Does anything come to your mind in listening to these discussions as the chair of the DH Bio?
Yes, thank you. Yes, I wanted to refer back to what was just said by Ross Upshur about testing the immunity passport, because we kind of slipped in onto that road. But I wanted to draw attention to what was first said in the presentations about the testing and the massive insecurity and uncertainty that we have with the validity of the tests. And speaking of which, I would like to also ask, why are we promoting mass testing and promoting doing antibodies testing at a larger scale if it's so uncertain? And because what is the end to it. I can see that there's of course, that there would be a great benefit for research to get a hold of how many in the community have been affected. But it doesn't really work with what we know now scientifically from these presentations and from this discussion about immunity, which seems to be the reasoning that has been presented for the reasoning for having more tests conducted, and why the public is also interested now in having themselves tested. So perhaps if you would like to comment on that, it's more of a statement that I would like to hear your comments on. Why are we promoting mass testing at this stage on antibodies?
So we need to distinguish immunity from population exposure. There is very important things to know about, so setting aside the reference standard question, which is soluble in time, but from a public health perspective, knowing the rate of exposure in the community tells you a lot about spread. It also tells you a lot about the potential denominator and reservoir of vulnerable patients. So we need to separate out what you can do with antibody studies in terms of population health, surveillance and characteristic from this concept of immunity. They're not necessarily entailed, and that's why I separated immunity testing as a policy and didn't put it as a goal of public health, because it's really important to know how much of the population is still vulnerable. Because I don't think any system can be confident right now. I still think there's probably over 7 billion susceptibles on this planet. And so any system claiming success should claim it very modestly and not very loudly and not for a very long time. But that's my own view.
Thank you, Ross. Thank you. Oh, Dominique, please, briefly, thank you.
If I can add, there is also the concern right now in any country of the world of the capacity of the healthcare system to cope with a wave that will be too massive for the healthcare system to support. And so if you have a systematic policy of testing, and I'm talking about the diagnostic, the PCR, not the serology, when you have such a policy, you have the capacity to install protective and preventive measures based on isolation or quarantine that will lower the wave and make it more, manageable for the healthcare system. So this is also, I think, a very important element that we have to take into consideration, because otherwise there is a risk, and you can see it right now happening in some countries where the healthcare system is overwhelmed. Most of the European countries, again, have been able to cope with the first wave, luckily, but it took a lot of energy from the population, and some population, I'm thinking, for instance, in Italy, in Sicilia, and other places where they have suffered so much on the human point of view. I'm not talking about the public health point of view, but really the social and human point of view, and this is something we have to be extremely careful about as well.
Dominic.
I agree.
Thank you, Dominic. Thank you, Ross. We're down to the last 7 minutes before wrap up, so really time is flying. I know that Lawrence has another question coming in. I'd also like to, if we can, bring in Pierre and Pete as well in the discussion before we wrap up. Lawrence, you have the floor.
Thank you. Actually, there is one question about tracing apps that I wanted to raise also, even though it's not really in the scope of our discussion, but we thought it could be interesting. But before that, if we can, there's a question who just arrived about what is there any kind of legitimacy feasible for connecting a serological status to a specific preventive measures against viral transmission based on all what was said? So could you connect a serological status? I mean, so in individual situations with preventive measures against viral transmissions, is it possible to do that? Is there a legitimacy on that basis?
Ross?
Not yet, as far as I know. And with respect to I don't think it tells us anything because we don't know about the possibility of reinfection at this stage. With respect to apps, I think there's going to be a convergence of serology testing and apps that are going to pose some very interesting challenges for health systems and policymakers. We've already seen that convergence occur in other jurisdictions, and it's going to link into the whole artificial intelligence discussion as well. We need like 20 webinars to get through everything here.
Thank you, Ross.
Dominique.
Dominique, briefly, and then I'd like to bring some reactions from Pierre and Pete very briefly. We're really down to the last 5 minutes. Thank you. Please, Dominique.
Well, I wanted to ask a question to Ross because I spoke in my presentation about the sewage epidemiology, and I'm very surprised at this moment that it is not becoming a broader topic at WHO and at the national level, while actually it presents a lot of benefit without the risk for the individuals.
Well, I think there's a lot of research into that. So I know, for example, that the Canadian Institutes of Health Research just funded a sewage study. Those of us who also have a background in environmental health are very keen to see. I think that you've pointed to some of the merits, but it's completely untested at this time. And, you know, I'm old enough not to be enthusiastic about things because the bugs always show up. And once you start, you know what they say about the road to hell. It's not paved with bad intentions. See, it might be useful, it might not.
And don't believe the hype. Pete and Pierre, can I bring in some reflections before we slowly shift to the end part? Anyone? Anything further? Pete, please.
Thank you. I realise time is short. I mean, there are many questions that have emerged from this, as with any good conversation. There are a number of tests that we've discussed today, but I kind of wanted to set them, given that none is absolutely determinative, within this broader question that we've touched on of risk assessment and risk profiling, particularly individual risk profiling. And I mean, there is work going on to identify those who are at higher risk of more severe forms of COVID-19, perhaps for genetic reasons, perhaps because of the state of their thymus glands. In other words, it is foreseeable, I think, and it seems to be where policies are heading in a number of jurisdictions, that we sort of flip the lockdown so that instead of locking down the majority of the population, we're locking up the vulnerable in a way that effectively where we have effectively socialized the costs through the lockdown, we are sort of individualizing the costs now. And I think that has some particularly from a sort of point of view of our duties and obligations to individuals, some consequences that we probably need to think through. And where I wanted to take that, and there's not really time to expand on this though, is in thinking about more generally coming out of the crisis, how we value public goods in general, because this is not simply a crisis in public health, it's a crisis in public health and in social relations, in economic prosperity, in social justice and all of those things. And I think what it should do is provoke a reconsideration of how different public goods are valued. And when I say how, I mean by what process as well as to what level. And one of the places that one might hang that, I think, is I think it's Article 3 of the Oviedo Convention that's been mentioned already, which has two elements about providing equitable access to health. Of course, one of the elements is that access should be equitable, but the other element is that there should be appropriate public health services. And I think Ross has pointed to this already, but I think coming out, setting that alongside these questions of economic prosperity, of security, of social justice, of all of these things, we need to perhaps reflect. And just to take it back to the WHO, I know that although maybe in a more limited situation, Mike Ryan in his press conferences at WHO has been using the phrase social contract quite a lot to sort of describe how this sort of social process could result in a kind of reevaluation of those things. I think that's a really interesting and important thing to think about. So thank you very much for your presentations and for allowing me to participate. So I'll sign off now.
Pete, thank you very much for that reflection. Thank you. Pierre, would you have a very, very short 1 minute reflection before we go to close? Very briefly.
I think, first of all, thank you everyone for inviting me, and thanks for Dominique and Ross. Nice presentations and very stimulating. I think what we're doing here is what we're used to do in medicine. I'm also a primary healthcare physician, Ross, but I do philosophy of medicine, and that's the reflective practice issue. And the reflective practice here is what is public health, and when does public health become more utilitarian than usual, and how is that going to affect the trust of the public? And as a final comment, I would say, besides sort of we've been studying disaster bioethics, and we're a bit disappointed that things were not taken up, there's also the precautionary principle, which could have been invoked earlier. This is not just preventive as sort of isolating people, but could we have, part of our reflective practice has to be, could we have used the precautionary principle to, in the future, isolate for a while the country of origin so that it doesn't become a pandemic, and not preach solidarity, but at the cost of almost now 500,000 lives. So, thank you very much, everyone.
Thank you, Pierre. There's some. My mic keeps turning off, I wish we had more time. I wish we had more time for. Maybe we need more webinars, but we'll see about that. I want to now take us to the last chapter of this webinar before you all leave us. We have 4 minutes left. I'd like to have some very, very quick, we've already given some, but very quick reflections, wrap-up messages, key messages from Ross, from Dominique, and then we're going to conclude with Tessie for the final words. Ross, please, and then Dominique.
Yes, thanks, Pierre. Thanks for ending on precautionary principle. I think that's a really important consideration. What we need is a robust approach to inference in pandemic that equally balances ethics and science. And what we've seen is unfortunately, both sides pouring more concrete in their silos to try to separate out. The reason I raised the concept of inductive risk was largely to connect facts and values and to create the space where ethics and science should be in conversation with each other. It's interesting that there's a big debate right now, John Ioannidis, Nassim Taleb, Mark Lipschitz, on what kind of evidence science can provide and how precautionary should we be in our deliberations. I think that's a really fascinating topic for the future. So be skeptical of science. Don't be afraid to start asking questions about what kind of society you want to have. I'm from the prairies in Canada. We have a strong communitarian tradition. Communitarianism and public health go together, as do utilitarianism and public health. Thank you for the opportunity. We've just scratched the surface on really fundamental questions.
Scratch away, Ross. Thank you very much. Dominique, 1 minute, please, for wrap up.
Well, thank you very much for this unique occasion to dialogue with so many experts and competent experts in this field. I think there is one element that come out also of this discussion, is the notion of preparedness. And you can see that there are countries where the legislation is not in place, where the structures were not properly in place, where the public health experts were not taken seriously from the beginning. And there are elements that we have to build on. You are going to have a seminar on health literacy. I would like to speak about legal illiteracy as well. And it's important to underline, as I've said in my presentation, the fundamental need to include human rights as a tool to evaluate the implementation and the level of preparedness of every country in the world facing a pandemic. Last but not least, I think it is important to remember that the law is one of the most important social determinants of health. And my last slide, I didn't show it, but I do a little advertisement. I'm giving a lecture, it's online lectures in August about better health faster, or better using the law to fight COVID. And I think the law here is as important as the medicine.
Thank you. We're down to the last minutes. I'm sorry, you should have had more time, but can you wrap up in 1 minute? Can you give us some reflections for DHBio going forward, please?
Yeah, having regard to the very limited time, delayed because I'm experiencing some delay here, I will just cut to the chase and say first, thank you very much to our speakers. It's been a very interesting session and discussion. And I would like to wrap up by saying that we've heard that policymakers are now trusting science and making decisions based on the science that we know, as we know it. And there's a lot that we don't understand about the science that is out there. For instance, there's a lot of uncertainty that has to be communicated somehow, not only to policymakers, but also through media to the public, so that the public knows what the testing and what the validity of the testing is and what you really can do with that information, but also how your information is used. Such. And without talking too much about that, I just want to say that these two webinars will really have to be concluded by determining the DHBio's role in all of this. So we would like for all of you attendees to come back to us at a later stage, because the Bureau is now looking into what the DHBio's role is in this specific pandemic, what different human rights questions we need to address. And as we've heard now in the discussion, there might be some questions. Mr. Sprumont mentioned that the role of human rights is fundamental in the pandemic as a tool, and that we need to rely on international health regulation. Is there anything lacking from the Oviedo Convention where we could that we should review? Are there aspects in the Oviedo Convention that we need to develop or perhaps work more with? So we have a strategic action plan that we have adopted quite recently, but we're now looking into what more actions we should take in the light of the current pandemic. And there might be some elements that we need to look more closely at. So the Bureau will be coming with some proposals for the DHBio to take action on certain elements. And we probably have to narrow it down and prioritize what will be the most highest priority, and especially looking at both our remits for the DHBio, but also looking at what other committees are doing and what our specific role is and what's current here and now. I mean, we will be talking about vaccines, for instance, but I think that will come later because at the moment we don't have one. So what's relevant right now is to talk about what's going on in the context of the pandemic at the moment. So thank you so much for all of this, and I will hand back to Lee to end the session. Thank you.
We're out of time. And we need to finish now. So thank you so much to everybody from us, from the Secretariat. Thank you to Ross and to Dominique, to Tessie, to Pete and to Pierre, but also thanks to everybody attending. I can't see you, but I feel that you're nodding, and I hope that's the case. We'll see you next Tuesday for the Health Literacy webinar. The webinar is closed, and have a lovely weekend.
Thank you, everybody.
Thank you. Bye.
Bye.